what is our goal with this? Jason and I have been talking about having him increase his skill set in the world of dental sleep medicine. It's kind of where the conversation started many moons ago. And he's expressed interest in helping patients in a way that is much more life impactful, so like potential for life changing than say doing a class 2 composite. Not that class 2 composites aren't important, but as we become more competent as dentists, it's nice to have other skill sets. And one of the things that I advocate for with myself and with those around me is expanding your skill set away from what a dental therapist can do. So you can imagine in 10 to 15 years when the market is starting to consolidate, and maybe it'll be 30 years or 50 years, but it's going to happen. And lots of data points to confirm that at some point, what we were taught in school, the bulk of the bread and butter dentistry we do, will be delegated to a different tier provider. Well, I would want an escape plan, and that escape plan is learning the specialties, learning stuff like this. So consider this an investment in your time and, in the long run to add a skill set that makes you more valuable in the marketplace as additional providers come in. Not to mention, a lot of what we're going to talk about is supremely relevant to a class 2 composite. And there's all kinds of examples that will tie in where basic restorative dentistry is dependent upon the jaw position and the health of the joint, the health of the muscles, myofascial pain disease, so on and so forth. So what I wanted to do was this is a presentation I gave at the Greater Portland Dental Society years ago. I'm not going to go through the presentation, but I just want to use some of the slides. And the first series of slides was something that, I wanted to paint a picture that I had never seen before. And it was the fact that the mandible is detached from the skull, which is obvious, but where does that mandible live in relation to the skull? Well, there's two determinants. One is the joint and the other is teeth. Without teeth, the jaw would be more superior. Without the joint or degradation of the joint, the jaw would be more superior. Now the muscle helps get you to that point, but the muscles, I don't want to say they play a lesser role in determining the position. The muscles are just as much part of the system. But the point I'm trying to make here is, where does that thing go? What's the answer to this question? And the gnathologist, so gnathology is the study of the gnathologic system, which is the teeth, the surrounding structures of the teeth, the muscles that control the jaw itself, the joint, and the soft tissues and the swallowing complex. So it's the oral system, but more than just kind of what we see when the patient opens their mouth. It's the stuff behind the scenes too, and the neuromuscular being part of that. So gnathology was, very alive and well in the early 1900s, and several people came along like Jankelson and Pankey and eventually Dawson and Piper. All of these big names started to take a role in what defines this system. What are the determinants of a healthy system? What are the constituents of a dysfunctional system? And there we have occlusal theories. Occlusal theories are defining as how the teeth come together, but in reality, it's more than just the teeth. It's the joint and the muscles that control it. Here's the question: does it matter? Let's see if we move that off to the side. So does it matter? And yeah, I think we all agree it matters. But who are the patients it matters? Who are the patients where it doesn't matter? And how do we answer those questions? Is where this intersection of the jaw, the muscles, the teeth, and restorative dentistry intersect. Jason, did this initiate any thoughts at this point? I mean, this is all basic. But.
Yeah, one of the things I was thinking of, how they say, because you were talking about just also like being the bread and butter dentist and like it all matters kind of thing. How they say like 20 80% of your problems come from like 20% of your patients or whatever. When you're doing the restorative dentistry, it's like a lot of it is this stuff. Like the 20% of patients that are having issues with some, it's not all the time, but you get my gist. It's like, why is this filling not working? Oh, you did this filling, now it's all off. Everything, nothing fits right. My jaw hurts now, and then you spend 8 follow-ups trying to adjust bites, and maybe we'll redo the filling, and now my muscles hurt, and I'm having headaches, and you might need endo, and it's like, you're just like, I just did an MOD. Like, I don't, I'm spending so much time on this one patient. So it's like, yeah, 80% of the patients are gonna be fine when you do whatever you do. But I'd like to be able to handle better those patients that are, when I identify that it relates to this and it's not there are other issues that arise, obviously, with just restorative dentistry. But I do think a lot of them are related to this when it's those patients coming back. I don't know, why does this not feel right? The crown, everything's high, touching the crown, nothing fits right, so understanding this to me feels like I can just solve a lot of those 80% of problems for my 20% of patients, by just understanding this a lot more.
Yeah.
If that makes sense.
It does. It's very well said. The Pankeys and the Dawson Academies, Spear, Coyce, they're all attempting to do the same thing, and it's to create stability and harmony of the system. And when we do that, we decrease disease, we decrease biomechanical risk, we increase joint health, decrease muscle pain, improve airway tonality, so on and so forth. So just to kind of try to bring this kind of full circle, what is the goal of these continuums? It's to be able to identify the patients that need work before you do restorative work would be one of the goals. So if you do an MODBL on number 3 and the patient goes off the rail, could there have been a system where you could have screened that patient, and then before you did that tooth, you fixed their system, either with an orthotic, an equilibration, ortho, many different ways to fix the system, or you prepare the patient for it. So if you know they're a high-risk patient, and I think that's probably the lowest hanging fruit, is just learning how to identify these patients simply based upon, obvious is like redness of the masseter, right in their skin. I mean, it's just a red spot that might mean they have chronic irritation of the masseter due to overuse. That's kind of an example.
Could even just be like a history too. I definitely think
all of that.
Just hearing more patients who are like, well, it was, ever since I had this crown done at my last dentist, it was done like 10 years ago. I don't get crowns anymore. It was a bajillion follow-ups and still never feels right. It's still, it's like, I think like then I start to think, I think anything put in your mouth is going to have difficulty, and you start looking at their teeth, and it's like those cusp heights that interdigitate so specifically, and like you're just like, oh god, this just looks like a mess. Like if you don't nail it spot on, it's never going to be right, or nothing's better than what you have, kind of thing. And then it's hard to do dentistry on those patients. You shy away. I'm guilty of kind of being like, everything looks good, because I'm like, I don't want to open a can of worms. I've done it before to myself, and it sucks. Yeah. Where you're just like, hey, that tooth needs a crown, and then it just opens a whole thing, and you're like, I just wanted to do a crown. I don't know why this.
Well, hopefully through this process we get better at identifying the patients, preparing for those patients, and then also getting out of the weeds when those situations go awry.
Yeah, I think the preparation part would be great. And me, it's like I could, what I don't want to do is every patient I'm like, and then this could happen, and this could, right? It's like the no stone unturned, but it's like, it'd be so much better use of my time if that only goes to the appropriate patient, if I can help identify like, hey, I just, I see these things and you seem at a high risk for these things. So when it happens, then I'm not wasting all this time on every single patient, like casting a wide net. It's more specific.
Yeah. Using this diagram here, where does the mandible go? Does it go back? Does it go forward? Does it go down and forward? And does it matter? All of this is defined by orthopedic factors, the muscles, and where the muscles want to be. We all remember Golgi tendon apparatus. Like, what does that thing do? It's a stretch receptor that helps us know when the muscle is at its proper length. So we have these receptors on our masseter and our temporalis that basically say, you're too wide, you're not wide enough. Well, to satisfy all of those, there has to be certain three-dimensional criteria met. You have the nerves, which have requirements. You have the aesthetic requirements of yourself and the patients. The teeth, just like Jason was talking about, are steep cuspal inclines? Are they in crossbite? Are they entrapped in the anterior? The new one, airway considerations. And I know Jason and I have talked about this a lot. In the SPEAR world, EFSB is an acronym that they use to help with treatment planning. It's aesthetics, function, structure, and biology. And they've used that platform for quite a long time. They've now added airway before it, so it's AEFSB. So if SPEAR is now acknowledging airway as a determinant in treatment planning, yeah, we're there. And we've been there for quite some time. I did want to switch over to this guy here, Dr. Stephen Olmos. So he's a lecturer, but more importantly, he's created what's called the TMJ and Sleep Therapy Centers International, with over 60 centers worldwide. The reason I bring this up is I don't think I've ever seen a lecturer tie the two parts of the conversation together, TMD or TMJ and sleep, better than this guy. I have several hours of his lectures on Google Drive, so if you want to watch what he has, I'm happy to share it. The point of me bringing this up is really just to have the conversation about, we're talking about TMD really to help Jason with airway. And then as he becomes more adept at treatment planning and treating airway, also treating the joint. So our short-term goal here is to open up a TMD and airway center in southern Maine, probably this year, if not sooner, and bring Dr. Bryant down. I was at his office today and worked on some cases with him. Watched him do what he does and how he approaches patients. So he's very much a TMD dentist and does it as well as anybody out there. He'll profess he doesn't know what he's doing, but he's very advanced in his knowledge and understanding, and has had referrals from all over New England for many years. So combining airway with TMD, and then as time goes on, we increase the overlap of the two modalities. So we're going to kind of bounce around from joint to airway, in great part because they tie together. And if we come over here and look at the joint, just have a conversation about what normal anatomy is. Before we talk about the normal anatomy, I just want to kind of lay down the framework of why does airway matter. It's pretty simple. If I can articulate this in one contiguous set of principles. When our airway is compromised, we're more likely to live in a sympathetic state, fight or flight, especially when we sleep, when we should be in a parasympathetic state. So if not breathing, increased sympathetic tone, the masseter and the temporalis are very sensitive to sympathetic drive. These muscles are more active during those points in time, and the joint pays the price. So it's a very short trip when we say it like that, when we're trying to connect airway to TMD. Any thoughts, Jason, on that? Did I say that simple enough to connect the dots?
Yeah. I guess I think the joint is the last thing I understand, is the least of my understanding. It's sort of, but yeah, I mean, it's nice to almost visualize it in that way. It's cool.
Yeah.
Like, it's kind of like, that makes a lot more sense.
Yep.
Of how it interplays.
Now you can imagine if the temporalis and the masseter are firing on all engines, and the condyle is, the system's not working right, so the condyle might actually be pushed backwards. You're more likely to have anterior displacement of the disc, pinching of the posterior, retrodiscal tissue. That's just one example of what can happen. But you can also just have severe overload. So even though this is an avascular and non-innervated entity, the articular disc, the joint itself, when under pressure, even up against this, you'll get what's called avascular necrosis, and you get what are called osteophytic changes, which are essentially just degradation of the joint. You can think of it as arthritis. And the more we load the joint, however we're loading it, that's a potential sequelae. So when we take CAT scans, one of the things we're looking for, and during one of these sessions, by the way, Mitch and Elijah, we're going to do this every Tuesday night until we feel like we've covered all the bases. I'm pretty sure this will go on for a long time, so you guys are welcome to join, and I'll keep you guys up to date and issue credits as we go along. But one of the things... Go ahead, Elijah.
I was saying, sweet, thank you.
Yeah. As long as you wear your nasal dilator every time.
You're going to catch me every time. I can't help but have it on, honestly.
I'm surprised I don't have mine on.
I get shipped for it at work every day, and I leave it places, and but can't help it.
Hey. We'll actually talk a lot about the upper airway. It's very much connected to all of this. So...
Actually, real quick question. Those osteophytic changes that you're talking about, is that referred to as bird beaking?
Bird beaking would be a result of osteophytic changes. So bird beaking is when this part of the condyle breaks down to the point where it gets flat, and then you have this sharper angle on the anterior head of the condyle. So the flatter this top gets, the more sharp this angle gets, and that's what's referred to as bird beaking.
Gotcha.
I do think that bird beaking, and I'll be very clear when I don't know something. This might be an area that I'm incorrect. It might be representative of a condyle that has degradation on a pan and not so much on a CAT scan. And I say that because I've seen pans with bird beaking, and then I look at the CAT scan and it's not as profound. So just kind of keep that in mind, because we're going to talk a lot about CAT scans. You might not see bird beaking, but on the pans you would see it more emphasized, more exaggerated.
I wonder if it, and I could be just misunderstanding MRIs because I also haven't looked at a lot of them, but I wonder if it's because with the MRI, the patient's typically having more changes within the space related to either the muscles or the decreasing diameter, but width of the disc, versus the osteophytic changes and the bird beaking you're more likely to find on the pano because those are bony related changes.
Yeah. MRI. So I was saying CAT scan versus pan, not pan versus MRI.
I see. Sorry, I missed that. Gotcha.
Yeah. And I can see where that came in, because a pan and a CAT scan are looking at hard tissues in the same way, but there's something about the two-dimensional image in a focal trough, as that focal trough is trying to capture that three-dimensional condyle. I think the bird beaking might be exaggerated, so it's partly a two-dimensional artifact of a three-dimensional representation. So let's explore, we'll explore that once we start looking at some CAT scans together. What I would say is bird beaking, my current understanding, is more commonly seen in degraded condyles on pans, not so much on CAT scans. But what I'll say is, in today's day and age, we're not going to use pans to diagnose anything with the joint. I say that with some degree of hesitation. A CAT scan gives us so much more accuracy. It's three-dimensional. We get to look at the disc. We're going to talk about the disc. There's the medial pole and the lateral pole, and which one is more important, and when we get displacement, what's actually happening there. It's a highly irregular entity, and at least when I was taught in school, I was just taught on two-dimensional images. So understanding the joint in its three-dimensional representation by looking at CAT scans in a 3D rendition is going to be very, very important as we unpack this further. But the point is here that degradation of the bone of the condyle on a CAT scan through seeing radiolucencies or osteophytic changes is representative of active inflammation in the joint space. So when we take CAT scans, we're looking for those. Those tell us we have active inflammation, which tells us the joint isn't functioning properly. That's just a part of the puzzle. And we'll unpack what that means in great detail, but it's good to know what we're looking for when we're looking at a joint and trying to assess what's healthy and what's not. With the CAT scan, that's one of the things we're looking for. We're also looking for the space. As Elijah was saying, there's a term here for the compartmental space, which is occupied by the disc, but it's also occupied by some fluid. And if you have limited space, that might give you a clue that the disc is anteriorly displaced. And as I think we all know, looking at the disc on a CAT scan is not really possible, although you can see it sometimes, you can see shadows of it. Reading MRIs is something that Dr. Bryant is going to help me with. He's very good at reading MRIs. He refers a lot of his patients to imaging centers to read the MRIs, and he's actually going to go over them at Learn at the Loaf in great detail. He's got, 300 slides that he's got prepared for that presentation. And we're going to be going up next Wednesday, I believe. He's going to be doing a dry run with the Kennebec Valley Dental Society. So I'm going to go up and support him and start the process of learning about MRIs. But he's going to talk about all kinds of things related to the joint and what he's trying to do when he makes an orthotic in the mouth to help this heal. And when I was talking to him today, he used a really good analogy. When you have a broken leg and you use crutches, the crutches aren't doing anything other than relieving pressure off of the thing you're trying to let heal. And that's really what orthotics are aiming to do, is to give the joint time to heal through removing pressure. And knowing what appliance to use and when is, a whole part of the conversation we'll unpack. Another part of this that's helpful to know, the superior belly and the inferior belly of the lateral pterygoid. The superior belly inserts on the disc, and the inferior belly inserts into the head of the condyle. That comes up. There's definitely times when you might have hyperactivation of the superior belly, which causes a lax joint, a joint that has stretching of the retrodiscal tissue, for the joint to come forward more readily, the disc to come forward more regularly. There's also the connection between turning off the lateral pterygoid by having things like anterior deprogrammers and all of that, and how it plays a role in diagnosis and treatment. The lateral pterygoid is a very important muscle for us to know and understand. It's also worth saying that there's quite a big debate on whether or not you can palpate this muscle. And my thought is it's possible in some patients with highly experienced diagnosticians. That's my current thought. It's pretty hard to get there. You can assess the health of the lateral pterygoid by other means, and Dawson does a pretty good job of explaining that, and we'll dive into that in due time. But assessing this like we would palpate the masseter is not the same. So what's nice about the masseter, it's very easy to find taut muscle bands or trigger points. Same with the temporalis. The medial pterygoid's a little easier, but the lateral pterygoid not so much. Another connection between airway and TMD is the medial pterygoid, which lives kind of on the other side of the jaw in this area, is very much part of the tonicity and tonality of the airway. So if you have a medial pterygoid that's in spasm, you can have an airway obstruction. And why would a medial pterygoid be in spasm? The system's in disarray. So another connection between airway and TMJ.
A question about the palpation of the lateral pterygoid.
Yep.
I learned that you can palpate it posterior to the maxillary tuberosity, and so I actually investigate that pretty much with every person that I get for an LOE or even mentions it during their exam. Reach up there and you kind of just like feel around, and you can eventually find a spot where the patient feels pain if it is a trigger point or like a muscle knot. What I've found anyways, and then performing a release can often improve things acutely. And then same with the medial pterygoid, I do like a bilateral press. I can't remember the exact anatomical landmarks, but it is like lateral to the teeth, medial to the ramus, lateral to the ramus, and they often have pressure points there as well.
Yeah, I'd love if we maybe extend this to a hands-on session where we, share these kinds of things. And I'm very open to the fact that my training didn't highlight the ability, but I've heard several oral facial pain experts say you can't palpate the lateral pterygoid. Anybody who thinks they can is just making it up. But then I've heard very good people say you absolutely can, and your anecdotal evidence is supportive of So jury's still out, but I don't feel the need to palpate the lateral pterygoid, in great part because there's diagnostic ways of testing. Just having a simple test is just holding the jaw and having the patient protrude forward. So you're basically applying pressure to the only muscle that can pull forward. And if you isolate the muscle and it's in spasm, it'll hurt. So there's other ways to indirectly kind of assess the health of it. But yeah.
Do you have a patient bite on a cotton roll when you do that, or do you do it without any opposing forces?
So if I'm having biting on the cotton roll is more, I think, load testing when you're trying to assess.
Yep.
You're trying to get the condyle to seat superiorly under vertical compression. There you're really trying to get a sense of is this inflamed, or are they pinching the retrodiscal tissue by isolating all of the muscle force pretty much posteriorly. So cotton roll, NTI appliance, anything like that isolates the pressure to the joint is what Dawson would call load testing. You also have the patient bite down on those to deprogram. So that's another way of turning off the lateral pterygoid, is to have them hold a cotton roll passively for 10 minutes. And I don't think that's what you were referring to, but there's several uses of a cotton roll in between the front teeth that achieve different goals. But as far as testing for the lateral pterygoid spasm, I would just have them do this. Kind of protrude forward under resistance. It's rather obvious.
Do you push against their protrusion forward, or do you not apply any opposing pressure to the chin?
It's like plyometrics. So you're not pushing it.
Like you are opposing while they are pushing, like that.
Correct. Yeah. So I'm not pushing back. Okay. I'm providing resistance as they push forward.
I see. Okay.
Yep. Yeah. Anything else about this simple diagram? One thing that's of relevance is the proximity of the ear canal. It's not uncommon the patients that have TMD, and by the way, when we say TMD, we're talking about intracapsular and muscle as one condition, but they're really two different syndromes. I don't know if I can use the word syndrome, but two very different conditions that all fall under the umbrella of TMD. So if it's intracapsular inflammation, it's not uncommon that they'll have tinnitus or ringing in the ear. And the reason for that is if this condyle is displaced backwards, and we see that a lot with entrapment cases where the anterior teeth are retroclined and the mandible's just not allowed to be free, it spends more time in the posterior disc space. There's a nerve, I believe it's the chorda tympani nerve, that has been associated with tinnitus. And it's not uncommon that I think a lot of our referrals are going to come from ENTs that are not able to treat tinnitus through the ear canal. And I say through the ear canal, if they cannot find ocular etiologies to the tinnitus, you know, we're going to educate them, send them to us, and we'll see if we can help. And then we just provide them with an orthotic to free up the mandible so that it can come down and forward and provide decompression of the joint and see if the tinnitus improves. And I've done that with, I'll say hundreds, but it's helped a lot of people that have had tinnitus. So yeah, we'll dive into that. Just kind of keep it in the back of our mind that there's other structures here. It's not just a joint that sits by itself. It sits very close to many other structures, and you have the airway here too. So everything's related. So let's sit back over here. What is centric relation? I think we all know, I'm assuming we all know, the definition of centric relation has changed 7 times in the Journal of Prosthodontic Terminology, which is GPT-1. Well, GPT-1 was the first one. Look at the definition back in 1956. The most retruded relation of the mandible to the maxilla when the condyles are in their most posterior unstrained position in the glenoid fossa. It's very different now, and we can dive into what the current definition is, but it's not the most retruded position. From a dental perspective, that's kind of the feeling we have. When we look at the teeth, it seems like they're going backwards, but in reality, there's a rotation and a translation component of it. And when you combine those two things together, you're often getting something very different at the level of the condyle than what you're seeing with the anterior teeth. Anybody want to take a stab at what that joint is referred to as? It's the only what joint in the body?
Gumfosis? No.
It's weird because it's like hinged on two, in the same axis on two things, but I forget what it's called. That's why it's so complex, though, right?
Yeah.
It's like it's got the same axis. No other joint in the body has that. I forget what it is. Double hinge access. I don't know.
I might butcher the pronunciation, but it's giglomo-arthroidal.
Oh, yeah. That sounds right.
Yep.
I think that was a board question, if I remember right.
Yeah.
It was, absolutely.
Understanding that the jaw joint, depending upon where the fulcrum is, you know, it changes its lever classification. So where the load is in relation changes it. So you have class 3 lever. So one of the nice things about anterior deprogrammers is we're actually changing the lever system. And what that does, it decreases the amount of force that the muscles can exert back here. So an anterior deprogrammer acts as a mechanical advantage, but it also helps to turn the muscles off because the muscles just know that they can't do it, so they tend to go, yeah, I'm not going to be able to do much here, so I'm just going to turn off. Whereas if you put a nut at the hinge, so think of this as our second molars, there's a lot more muscle potential, a lot more force as we get closer to the joint, and that's, you know, a concept that we're going to use quite often. Mutually protected occlusion. You know, we could dive into occlusion at some point. So this picture here I really like. This comes from Dawson. He's got a series of these photos where he has plus signs and minus signs on the muscles to indicate whether they're activated or not. And when you have a posterior prematurity, really all of the muscles fire, in great part because the brain thinks that's food or it's something hard. So the muscles have no idea that's actually your tooth. The muscles are assuming that you had proper craniofacial growth and development. I'm going off on a tangent a little bit, but picture tens of thousands of years ago when a baby breastfed, and as soon as they were done breastfeeding, they were eating raw meat. They had very large jaws, their wisdom teeth had space behind them, they had very large nasal cavities, and what's the word I'm looking for? Anthropology. So if you look at anthropology records of skulls before a certain period of time, there was very, very well-defined occlusions, craniofacial development, arches, nasal passages, airways. My point of bringing this up now is because we're restricted, we now live where posterior interferences are actually pretty common when our muscles were developed during a period of time when those weren't present. So when we get these posterior interferences, the muscles are like, hey, this is something hard. I'm going to increase the force to try to compress whatever's there. The problem is our teeth aren't designed for that. So it'd be like chewing on a glass marble. And that's where we see a lot of emergency patients. So really what Dawson tried to teach was getting these teeth to come together in harmony. And a lot of what he talked about was equilibrating the teeth. And yes, there are a subset of people that's the truth and that's relevant, but not everybody. This here, he has a saying, lines in the front, dots in the back. So that's basically a very well equilibrated orthotic, or an anterior deprogrammer, or proper occlusion with anterior guidance. And as you can see here, that if you have lines in the front, that's anterior guidance. And if you have proper interincisal angle of the front teeth, then your muscle patterns look like this. The elevator muscles turn off, the inferior belly of the lateral pterygoid fires, and the anterior temporalis fires. That's very low muscle activity. Now, what do the neuromuscular dentists do? They actually measure muscle activity. So they use EMG to kind of get a sense of what is the muscle activity doing when teeth are related to each other in various ways. And then they draw conclusions based upon that. I'm not here to say neuromuscular is right or wrong, but it is a tool to get patients to a healthier place. And I know many neuromuscular dentists that do wonders for patients. But the gnathologist would say, we don't need to know what the muscles are doing because we know why they're doing it. We need to fix the why they're dysfunctional, and we know what a proper occlusion should be. Let's fix that and then watch their symptoms improve. So different ways of trying to get to the end. This is a slide I had created years ago for me as I was starting to take lectures, and I realized that there were kind of these general themes of occlusion and gnathology. And I kind of broke them up. This was primarily for my understanding, and then when I did this lecture, I decided to kind of share it with the group. And I don't know if it resonated or not, but I'll share it here. And we're going to talk about occlusion. And occlusion can be thought of as an extension of the gnathologic system. So, and TMD living within that, airway living within that. So there's kind of that first phase of it, which is to encourage a healthy system, craniofacial development. So spending a lot of time helping kids during their formative years to do things that foster the kind of craniofacial development that our ancestors enjoyed. I spend a lot of time every single day having my kids bite down on things pretty hard. So they eat a ton of carrots, a ton of cucumbers, and whenever I'm with them, it's always let's see how hard you can bite it, and let's bite in the front, and let's bite on the side. So what I'm trying to do is mimic our ancestral habits of eating, where we're actually activating the muscles to stimulate craniofacial activation. When we say craniofacial, what we're saying is if the muscles are working hard, the bones underneath them, through Wolff's law, will grow more readily. If they're not active because they're eating pureed food all the time, you're not going to have craniofacial development. Well, genetically, the soft tissues that surround that are programmed to grow to a certain size. So you're going to get tissue in the airway, but you don't have an open airway because the skeletal structure, the scaffolding within it, didn't grow. And that's where a lot of our problems come from. So this first phase of encourage through some of these tools that we just talked about, phase 1 orthodontics, is really meant to improve the system at an early age when we have the opportunity to intervene. But as we move forward, let's just say they're done craniofacial development, they're 18, 19, 20 years old. Now what do? Well, we can maintain their VDO. So giving a bruxing patient in their 20s a Brux guard, that's what we're doing. We're decreasing the odds that their system will unravel. It's more than just, we don't want you to crack your teeth. It's, we don't want you to lose tooth structure and lose vertical dimension in the process, which has a lot of systemic effects. Prevent the need for therapeutic, basically saying that prevention is always better than treating a problem. And then we have, all right, the problem arose, and now we have the therapeutic measures, full mouth rehabs, TMD, dentures. So it's just kind of a way to think about the hierarchy of age and progression throughout life and where this all matters and where it plays a role and the different things we can do to intervene. Any thoughts on that?
Just wondering what you mean by TMD for therapeutic. Do you mean temporal-mandibular disorder, or is that a treatment?
Yeah, the disorder, so treatment of the disorder. So orthotics, equilibrations,
Yep.
so on and so forth.
I think it'll be just interesting. You know, I feel like, yeah, I mean, I see that as like an age thing, right? So we are where we are, and we treat a lot of the people born in the 40s, 50s, 60s, 70s, what have you. And that's the people who just have suffered from a lot of these issues. Like they were just fed baby food. It was, you know, the 50s, baby food was a huge thing. The pureed foods, there wasn't a lot of orthodontia, early phase orthodontia. Like, so we're treating a lot of these older cohort of patients, the boomers, whatever, the baby boomers. I wonder with this young generation, because we're starting to, in probably the last 20 years, just understand all of this stuff, maybe even 30, because like I had palate expander and all this stuff. So it'll just be interesting to see if some of the problems are less and less. There will always be the people who just lacked access to care and those kind of things. But I will wonder if we're going to, as a population, at least maybe in our nation, just like in general, help prevent a lot more problems. Because it's just, there's so many times we see a 60-year-old guy and it's just like, God, I wish someone would have seen you when you were 20. Oh, they said I could break my jaw. And I'm not doing that. It's like, yeah, it's way simpler these days. Like it's even that surgery is, I mean, it's not simple to go under the knife, but you know, I don't know. It just seems like
it would be interesting to see, and I have no doubt that'll be studied. But my gut tells me that the amount of, so when I go to Hannaford, for example, I just look at the food and I ask myself, what percentage of this food would stimulate craniofacial growth? And it's not much food there.
not a lot.
You know, it's the vegetables, and that's about it. Well, just because we have this awareness in society doesn't mean the average patient's going to actually put it into action. As much as I know about this, it's a tall freaking order to get your kids to do it every single day. And I have no idea if I'm making an impact or not. I'm basically just taking my understanding and trying to give them the best chance possible. when, 10 years from now, I think I'll have a pretty decent idea based on the fact that my whole family has a narrow palate, narrow jaw, crowding of lower teeth. So if all three of my kids kind of show up differently, then that'll be a good sign. But maybe they didn't get my tooth genetics; they got Danielle's, and her family is more expansive.
But then I think the early intervention orthodontics can play such a big role in mitigating those problems. But
I have no doubt that, they'll be in braces at 7.
They'll be at the orthodontist by 7, definitely.
100%.
Yeah.
When I say braces, probably not braces, but
no, I know what you mean. But at least
expanders,
and at least looked at. What is the need? What do we need? And I don't think you can say that for a lot of those patients that we see that are 50, 60. It just wasn't a thing. Not as much. But like you said, I think we're still just there's just access to care and stuff, and what people are going to do is what people do, and what's cheapest, and people still can't brush their teeth. They're not going to,
Right. While we're on the topic of this slide here, adaptation of the jaw joint is a concept that I didn't really fully understand until I think it was during COVID. I bought Jeff Okeson, and we'll look at a lot of his stuff. So Jeff Okeson is, I don't know if he's still the dean at University of Kentucky, but he's really the godfather of the oral facial pain subspecialty, that his hope was to actually have it be a specialty in dentistry, where we get to a point where general dentists can refer patients with these kind of problems to highly qualified dentists that have specialty training in oral facial pain, and a lot of that has to do with TMD. And so I have taken his course online several times, and one of the times I bought it from him, his platform charged me twice, and I sent an email, and I get back, he's replying back, and I'm like, this guy's the dean of a dental school, and he runs this TMD oral facial pain continuum, and he's returning my email. Wow, I feel special. And I've had his textbook for years. I've read it, and to me, he's somebody that would not be replying to his emails. And he said, well, I don't know how to fix it. What can we do? And I said, well, it's COVID. How about you help me with 3 cases? And he's like, fine. So I actually have 3 hours of recordings of me and him talking about just questions I had about cases and like how he would approach them. And the thing that he taught me the most through, one, reading his textbook, but also talking to him during these sessions, is the fact that the joint is rather adaptive. So when we have, and this is kind of a touchy subject with a lot of dentists, if a patient has acute TMD, time is a therapy. And that's such a hard pill to swallow, because are you ignoring the patient by telling them that? We all know many dentists and physicians that will say something to the effect of, let's just see how it goes. What they're saying is they don't know what the hell's going on, and let's just see how it goes. But actually using time as a very distinct treatment modality is a tool in the toolbox. And the fact is that the joint is highly, highly adaptive. So he spent a lot of time talking about that, and I think we'll dive into it as time goes on. But I just wanted to make that point here that, sometimes what we need to do is just get the patient through the acute phase so they can adapt and their tissues change. And a good example is when the retrodiscal tissue, I said calcifies here, it's more sclerifies, becomes sclerotic. In essence, that tissue becomes non-innervated to the point where it's supporting the joint without pain. So we'll talk a lot about adaptation and the adaptive potential of the jaw joint. And the last thing I wanted to go over is this concept here, and then we'll call it a night. So here we are talking about gnathology, and Elijah would like to come back. How do we let him in? Let's go over here. We're gonna start charging you readmission fees there, bud.
So I missed everything you just said, but I'm assuming you were talking to me.
I was just saying we should charge you.
I was trying to unmute and then I accidentally clicked unjoin.
Ah, gotcha. So
I was going to ask you what time frame do you consider acute? Because I've done the same thing before when it seems like something that, like, I don't know how else to describe it, but jaw gets out of whack. They've got combination of disc displacement with or without reduction. It seems like they get like a pop or something, and then it kind of hurts, but it gets better after like 4 weeks usually. They come in 2 weeks later, and it's, I don't know. What time frame would you give?
It really depends on the diagnosis. I think you're probably talking about, so a common scenario that will happen is that anterior disc displacement without reduction, where they get stuck behind the joint. So with reduction is more of a chronic condition where the joint is so lax that it just kind of pops on and off. And that tends to be the lateral pole. But the one that really bothers people is when it's kind of like a full disc displacement, maybe the medial pole and the lateral pole of the pole is part of the condyle. The disc that sits on it can slip off just one side. It's not just this one pillow that comes back and forth. You can have displacement of either of those two components. And depending upon which of the two is displaced, well, most of the time it's both when we're talking about these more acute situations, the patient gets stuck on the retrodiscal tissue. And those are the patients that will say, I heard a pop and then I was stuck, maybe not fully open, but they were stuck in a position. Those are the people that you gotta, typically treat with some manual repositioning. We can dive into that at some point, but those acute situations are typically treated by pharmacotherapy, just to decrease the inflammation side of the joint, versus the more chronic situations where you're trying to decompress the joint from chronic inflammation. And we'll definitely dive into that, but it's hard to answer that question in great part because the diagnosis is very much dependent upon, or the treatment is dependent upon the diagnosis, and figuring out the diagnosis is really the hard part of all of this. So yeah, we'll dive into specific case scenarios on what we would do when, and I really think Dr. Bryant's going to do a good job of providing us a pretty deep understanding of what he does, and he's been doing this for 40 years, so let's definitely lean into him. So this last flow chart here, the gnathologic system, the teeth, the joint, and the structure. We can think of the structure as the craniofacial base, muscles in the bone, the dental, the periodontium, and the teeth. And then the teeth have enamel and dentin and the pulp. These are all part of the system, even though we think that we think of them as separate entities. They are literally part of the gnathologic system. But what's really helped me is this slide here. When there's stress in the system, that stress can be poor sleep quality, it can be trauma, all kinds of different stresses within the system. They all manifest differently from patient to patient. So you can have a patient that has muscle hyperactivity that has pulp stones, and that's it. Others who have tooth attrition and wear and bruxism. Bruxism is not a sign, it's more of a condition, but tooth wear due to bruxism as a result of stress on the system. You can have the muscles pay a price, and that would be myofascial pain disorder, which is really 90%, 80 to 90% of our jaw patients are the ones with stress in the system manifest in the muscles. And those are the people that have trigger points, tight muscle bands. They tend to do very well with Botox, where the muscles are turned off, physical therapy. The bone, when does the bone pay a price? Tori. So tori are literally a response to stress in the system over time, and there's a genetic predisposition to tori. but you can have the genetic predisposition, but if you didn't have stress, you wouldn't get tori. So tori are very much a representation of when the gnathologic system isn't functioning in harmony. Further down the stream, the periodontium, you can have mobility and recession. So these are now outcomes. And I have exostoses here, trigger points here under muscles. Internal derangement of the TMJ, pulp stones, abfractions, occlusal wear, recessional mobility. So whenever we see these, we have to think there's stress in the system. Automatically, that patient's a TMD patient, in my personal opinion. I don't want to say a TMD patient, but a gnathologic dysfunction patient. And that's really where Dawson and Spear, Coyce, Pankey, LVI all come in. When they see abfractions, they automatically know that patient needs a full mouth workup, because it's not, let's just put composite to fill your holes. It's, let's talk about why they're there. And that's really the bulk of full mouth dentistry, comprehensive dentistry, is understanding that these manifestations downstream are due to something upstream, and that something upstream is stress in the system. So as we hit our heads hit the pillow tonight, this is, to me, this is probably the most valuable take-home lesson that I've learned, come up with. You know, this is my interpretation of the system, but it's been very helpful when I go in to do exams, whether it's a new patient exam, limited exam, and I see these signs and symptoms. I'm automatically thinking there's something wrong with the system. What do? That's what we're going to unpack.
Oh yeah. Might be another, as we talked about, just like the high risk patients. You know, these might be another sign of just like helping to identify those high risk patients.
Yeah.
Yeah, I didn't even really think about like the pulp stones. I mean, I think I usually get the occlusal wear, but again, seeing these things sometimes is just really helpful visually, putting it in perspective.
Yeah. Alrighty. Hey, 9:10. That was a good hour.
Yeah.
Let's do it again.
Good, man. This is awesome. I'm pumped.
Yeah.
I'll join you. I'll join you on Wednesday, I think, for Dr. Bryant.
Yeah, maybe we'll take next week off from this and just, you know.
Yeah, and then we could reconvene. Like this is what we went over. This is what we learned. You know, we kind of go from there.
Yeah.
Yeah, but I'll plan to go either with you or I'll meet you there. We'll talk more.
Yeah. Let's.
I won't be at Sugarloaf, but he's actually going to be doing a lecture at the Kennebec Valley Dental Society, so I'm going to try to go to that.
Yeah, that's what we were talking about. Yeah.
Oh, you guys are going to that on the 29th?
Yeah.
Oh, yeah. Awesome. I thought you were referring to the Sugarloaf.
No, I'm not going to Sugarloaf either. But yeah, let's.